Ian, welcome back to the show, mate. It's good to have you back on.
Thanks, Andy. Thanks for having us.
So, we had you on an earlier episode where we spoke more broadly about how performance is managed and supported in elite boxing in your environment. But today we'll go kind of more into the hand and wrist shortly as today's topic. Just in case this is someone's first encounter with you, could you talk about maybe your background and kind of bring people up to speed?
Yeah, I'm a sports physiotherapist, been a sports physiotherapist really for over 20 years. And I'd say 12 plus of those years have been working with boxing. And say probably the last 3 years I've been head of performance services for them. But within that remit, there's obviously been a spectrum of injuries which boxers can get. I think sometimes people consider boxers only get injuries in certain areas, but boxers get injuries everywhere. But the reality is the upper limb is the predominance, and hands and wrists are our bread and butter.
Yeah. And what kind of things have you got going on currently? And as a bit of an update as a returning guest, what kind of current or future commitments do you have in sport?
Well, you found me really on an interesting period because we've literally just finished the Olympic Games, and boxing finished in the second in the medal table, taking home 6 medals: 2 gold, 2 silver, 2 bronze. Fantastic performance by everybody. You know, the boxers, the support staff, the coaches, everybody really worked fantastically together at the games. But it's beyond the games. It's the 5 years leading into these games, including the period of COVID. And just about we having finished these games, really, I'm working with Anthony Joshua as we record now. He's fighting next week in Tottenham Stadium down in London. So I'm in Sheffield today, but next week we'll be in London.
Yeah, so no, that's obviously a major focus at the moment. So, um, in terms of kind of getting into the meat and gravy of today's episode and talking about the sporting hand and wrist, what what led you into this as becoming an expert on this side of the injuries? Obviously boxing, but like what was your evolution as a practitioner with this as an interest?
Yeah, I think like happens with many physios probably when they work with a specific sport, it comes with the territory. I think before boxing, I did loads of different sports. Obviously, I've picked up all the different areas. The 2 years before joining boxing, I was working with volleyball, and you do get traumatic hand and wrist injuries. Obviously, you've got that predominance of the ankles, you've got the overuse of the knees, with the patella tendinopathies, but they do get hand and wrist injuries. But even though they did get them at the time, I wasn't in that sort of spectrum or mindset of hands and wrists are important, because you think what are the most common injuries are actually the ones that are going to keep them the most away, the most severe. But when I joined boxing, I realized straight away the hands and wrists are those areas. So I myself had to upskill myself. And in the process of upskilling myself, I realized that there was nothing out there. As in, when I started 12 years ago, there wasn't pretty much anything around hands and wrists. You had to like really look in different corners. I think as I kept on upskilling myself, probably I'd say 4 or 5 years into my career with boxing, I felt that as I started being asked by other sports to provide expertise, I realized that there was a hunger, there was a bit of a niche also in that area, and I think over the years I've pushed myself in that area to help other practitioners and other sports, to help other athletes. So within the English Institute of Sport, I am a technical lead or a consultant on hands and wrists. So everybody who's got hands and wrist problems that need further consultation, they'll come to me. Within my own sport, obviously, I provide our expertise, and even outside of the Olympic setups, whether it's rugby, whether it is tennis, whether it is a goalkeeper in football, I've had the privilege to see lots of different and complex cases, and I think in their own complexity, I think it's probably allowed me to provide a simple approach to things. because like anything else, when something is chronic, when something is complex, everything seems like it's a horrible picture. So for me, it was always about how can you simplify things and take things in a very methodological approach.
You mean like if I reflect on practicing in two countries, in the UK, obviously the NHS exists, and I was more than welcoming as a clinician to let hand and wrist patients, admittedly, slide into the NHS to see hand and wrist specialists there for rehab. And in America, in a different way, it's not too different in the sense that in a say private practice, it's very common for there to be half the clinician might be physios or physical therapists here, and then occupational therapists will take pretty much everything below the elbow. Once you go beneath, by classic American sports like a UCL for baseball, once you go more distal than that to the hand, it tends to go to the other half of the room with occupational therapy. What's like the kind of, maybe just from the UK alone, what's the current educational pathway, or how can people currently develop on the hand and wrist? Because I think it's one of those things that in the UK and America, it's very easy for it to be the sort of the weak region of a clinician's knowledge for those reasons.
You probably hit the nail on the head really. With you've got your occupational therapists that obviously they focus in those areas, but a lot of times I think there's probably a traditional route which takes them more towards your NHS type injuries, more like non-sporting injuries. So yes, you can have traumatic, yes, you can have overuse, but I think that sporting acumen doesn't really exist. You've got hand therapists, so you've got physios that can specialize to particular routes, becoming more specialized in hand therapists. And again, they follow more of that private practice, NHS element of things. And then in sports, you've got sports physiotherapists, and they probably are good in all the other areas, and it's the hand and wrist which misses them. So you've got lots of fantastic practitioners either working in hand and wrist but missing that sporting element, or physios in sports that miss the hand element. And I think what I managed to do probably is bridge that gap by discussing and describing the injuries that happen in sports. There's a lot of crossover with the injuries that happen in sports in the overuse non-traumatic injuries that can happen in your day-to-day, from your non-sporting or your sub-elite, to put it this way. I think what I've probably managed to bring also is maybe a simplistic recipe also, like, no matter the type of injury, consider the anatomy, consider the biomechanics, but try and simplify things, rather than, get lost into the pathology. Is the consideration around function and the consideration around, the history, the consideration around what really is the person telling you. And, the history for me becomes a very important component to it. So I think it's, there are routes to specialize, and obviously, hopefully people follow the educational material that I tend to provide. And obviously I know that we've put together two fantastic webinars, hopefully that people can get even more education around these areas. But there are traditional routes, and then there are obviously these areas which can help people want to specialize a bit more.
Yeah, and we'll obviously get onto the webinar and, of course, talk in a second. But I thought what was interesting is, we polled on our social media whether people feel comfortable and competent treating the hand and wrist as a clinician, and 81% of people said no. And I think, talking about specializing, I think, and everyone's guilty of it to some extent probably, but it's very easy to become a convenient specialist. And what I mean by that is, you have an interest in, say, ACLs classically, or something, one of the big rocks clinically, and you like ACLs, you know about ACLs. So it's a comfort point to keep consuming more interest, more topic and more education on ACLs so you kind of become very good at certain things. And then, like in any context, people don't always want to work on the side of their knowledge that's maybe less comfortable. And I'll put my hand up and I'll say I belong to that camp as well. But I found that interesting.
I was going to say, the one thing is that, I'd urge people not to think about the hand and wrist as an area of speciality. Nobody thinks about the ankle as an area of speciality, and they're very much biomechanical, have certain similarities. It's good to have people that specialize in those areas, like myself, taking it a step forward, so that you can feed that information. And when there's complex things which maybe they're struggling with, they've got somebody to get a second opinion about, ask questions or refer. But if somebody the learns the ropes, to use a boxing expression, just enough so that they can feel comfortable. They learn, okay, simple anatomy, simple biomechanics, and how to approach it. That's really what you need to do. You don't need to become, go down the route of becoming a hand therapist to see a hand and wrist, or an occupational therapist. No, if you're a therapist that sees backs, necks, shoulders, ankles, the way I try and provide the information is for somebody just to have an add-on. It's not to create a course that has 5 modules that you have to pass an examination at the end to get a certification. It's giving people enough information to then take away with and build on that already existing knowledge from other areas. So I think it is important, because, as you said, if the poll said 81% feel they're not comfortable, the 81% sometimes might be fearful that, it's going to be a lot of information for me to upskill, and it shouldn't feel like that.
Yeah. So hopefully the person listening that might belong to that same camp as me, the 81%, knowing that they maybe need to bring their comfort level up and just get up to speed on this area. Can you talk us through maybe the format of the webinar series that we're going to host with you?
Yeah, so the way we've sort of structured this series is we're going to have 2 webinars. One we'll do in the autumn period, and then the other one we'll do in the beginning of next year in January. We've divided them into 2 1-hour webinars, so you got 45 minutes of me talking away, and then hopefully there's time for people to ask questions. And I know these will be recorded, so they'll be available. One will be non-traumatic hand and wrist injuries, and the other one will be traumatic. The first one will be non-traumatic, and although we class this as non-traumatic, so the reason we've named them like that is traumatic is very easy to think. You've got that injury, you've got that sudden onset. Now, with non-traumatic injuries, there's going to be 2 types of things which I'd like to almost mention. So you've got I'd say the overuse injuries that somebody presents but they don't know the mechanism of injury. So the reality is there is some form of trauma, but it is very much at a lower level than the one-off. So I don't want people to feel that the title misleads. But then equally with that, whether you work in sports or not, there are certain things for us to consider, certain red flags. Whether it is some ganglion. And again, is that a ganglion or some form of cancer, that's some malignancy in the region? And that's one of the things, obviously, I'll talk about, red flags. And equally within the spectrum of that webinar, it's mentioning, that, again, you're not going to be there expecting that a big percentage of people walking through the door are going to have that. Hopefully not. It depends where you are in the world. So there's going to be the spectrum. Obviously, with the non-traumatic injuries, we'll talk about things like TFCC injuries, that overuse elements of things, tendinopathies, which fall into that bracket. We'll even talk about, even though scaphoid fractures, we tend to talk more in the traumatic, there's a non-traumatic element of it, your stress fractures, starting with a stress reaction. Hopefully you pick it up at a stress reaction level and you can calm it down before actually it becomes a fracture. Sometimes it's too late. Sometimes if the fracture comes on and it is actually as an overuse mechanism. So we'll talk about these things, and to help people also, we'll try and map it in such a way that, rather than just picking up, injuries at random, try and have a little map. So what are the injuries that happen on the ulnar side, on the radial side, dorsal voral, a bit more central, just so that little mapping helps a little bit when you are approaching your examination. But then, although we'll be talking about things which you'd want to diagnose, it's important to take a step back and think a little bit about the function. So beyond the element of what it could be, somebody presents with a scan and says you've got this, doesn't necessarily mean that their symptoms are definitely coming from those areas. Same as we've seen other regions of the anatomy.
Mhm.
The
Like
back
back
is one.
pain or
The back
yeah.
is one of the biggest ones where I talk about back pain. I mean, I've seen people sometimes, you do a scan, they've got something which is on the opposite side of where they have the problem. However, you need to consider in the spectrum of things whether biomechanically that is influencing the other side. So hopefully what we'll try and do is help people so that, if I'm sitting down and I'm talking with a client or an athlete, um, and they say, I've had a sudden episode, well, hopefully we'll cover the types of injuries that you could get in the second episode. But the first episode will be more about those occult or those, well, I can't remember, and it started to get a bit painful type injuries or type conditions also, because there's a couple of things for us to think about.
Do you kind of, just thinking clinically, one of the more common times you'll see a hand and wrist regional symptom will be like a radicular type profile. Do you cover that stuff in the webinar itself, or is that something that you see more as like the bread and butter education that somebody should have coming into it anyway?
Yeah, I mean, obviously, and we'll touch base on a few things, but as you can imagine, in 2 by 1 hours, we'll give enough information for people to walk away with some nice golden nuggets. But if you wanted to really dwell into a bit more the hand and wrist, probably you'd need a day. And obviously, I do separate courses and do different bits and bobs, as people might probably know. So you need a bit more of that information. Now, I wouldn't expect people to just go away and start reading lots of things, because the problem is you could end up reading things which could be useful and things which just take you down a rabbit hole, because even I mentioned the word biomechanics a couple of times. You could get really lost. I mean, I'm doing a PhD in wrist biomechanics, and if you go down the sports engineering papers around the wrist, you could literally go down in areas where you don't even know how that links clinically. So I think what I try and do is, obviously, where possible, simplify things so that people understand that construct. But we'll cover certain things, but you can't cover a lot of things in that short period of time. But hopefully, the people that join us live, they can ask certain questions, which we'll be more than happy to answer.
Yeah, and just for listeners' benefit, we'll host a Q&A on the live version. So I'll be on the call directing that. I just want to kind of park as much value in this episode as possible, as well as obviously for the people that sign up to the webinar. But this is a bit of a broad question, but have you got any kind of tips to clinicians on treating the hand and wrist based on maybe what you've seen as common kind of clinical skill or clinical knowledge deficits? What might be some low-hanging fruit clinically that people could find benefiting knowing now?
Well, I suppose the first thing is, which we will definitely cover in these two episodes, is knowing your common conditions. And also we'll chuck in there a couple of probably rare things that you might not come across, just to help out a bit. But it's having that and having that map, as I said, if you get Eddie Quervins, it's going to be on the right side. If you're getting TFTC, it's going to be on the ulnar side. And what is the type of pain provocation movements that you can get from that. I think that's always useful to have, because whenever you approach anything, I mean, there are people out there who hopefully they're really good at shoulders or knees. Surely when they approach that, they're going to have that at the back of their head. The other thing for me, with the hand and wrist, is understanding function, because if you know what the function of the hand and wrist is, what it is meant to do, and you've got the right tools to assess it, then that already can give you a lot of information beyond the diagnostics of, it could be a TFCC, it could be a scaphoid fracture, is the severity. So, if, for example, you are suspecting a scaphoid fracture and somebody can do push-ups in infinitum, that's probably taking a little bit away from, maybe it's not a fracture, or if it is, it's definitely not, highly symptomatic, versus somebody who, the moment they just put their hand on something with little weight bearing, then it's quite painful. So again, it's thinking about the function. And so there are certain things that we tend to talk about around objectivity, and we will talk about those things in the webinars to help people. And then sometimes, it's good to think outside the box. But the first thing is asking, what can you do and what can't you do? And then trying to replicate certain things in clinical practice. And the main thing is, it may help you or not in your diagnosis, but definitely will help with your prognosis. Because when you're talking about function, that's where people get a bit lost with the hands and wrist. We over focus on the scans, we over focus on the diagnosis. 6 months down the line, people are scratching their heads, thinking about injections and thinking about maybe reoperations if they already had one operation. And I've found sometimes just by doing the simplest of tests, just to look at function, you can literally make people believe that you've got nothing, and that's the reality. If it's useless trying to think what there is a lot underneath the hood if your function is really good. If somebody tells you, and this I had this recently, my hand is really good, it's only painful when I clap. That's one of the things I got, only painful when I clap. Well, that tells you there is something there, and I'm not going to take away the fact that you don't want to clap. So a couple of things, it's only one thing which is painful, so great. And then the other thing is, all right, we can start thinking about how are they clapping, what's the intensity they can clap. I'm using a very simple example here, but a lot of times you get that with people who say, yeah, it's only painful when I do that. And we get lost too much in the diagnostic element of things, trying to tell them, well, anatomically that's what it is. But you find that the function is really good, but you need to know how to assess it. I think that's probably my bottom line, and that helps definitely in the way one approaches a clinical assessment of hands and wrists.
Hearing you speak, people will be really, say you were comparing a knee or an ankle, clinicians listening will be very aware of the overlap in the sort of rehab frameworks or the principles of how those injuries prognostically improve and how you rehab them, and especially in a sports context. And I've no doubt that's the same with the hand, but can you maybe share some examples of maybe how you assess the athletic demands of the hand and wrist? Because I think it's one of those areas where people will probably credit that there's going to be ideological overlap with other parts of the body. But if it's an area they've got less exposure to treating, the examples on the forefront of their mind might just be lacking a tiny bit.
Yeah, so one of the things which I think is brilliant is you can use a hand grip dynamometer to measure strength. And although you're measuring strength, because it's peak force really, so you're measuring the highest amount you can do. And there are two ways of doing it, which you find in the literature. You can either do out of 3 and you find the mean, or you can do out of 3 and you find the max. It depends how you want to look at it. I tend to use the max because I'm really interested in how much they can squeeze and how much symptoms do they get with it. So rather than strength in itself, I'm looking for function. So can you make a power grip, which is one of the elements of the hand? There's lots of grips at the hands and the wrist, but power grip is one of them. And so if you know that they can do that, and that means that obviously there's a lot of pressure going into the bones, into the joints, that's already telling you that if they can squeeze and they can get exactly the same number compared to the opposite side, or roughly similar, and they have no symptoms, that's already really good. The next step from there for me is, if we are looking at loading, is then you can load them onto a stable surface. And again, you can do it just by eyeballing it. You put both hands on a clinical couch, for example, or a table. You put more weight, you put less weight, you put one hand, you do a push up. So you can do that. But, if like me, you like numbers and you be a little bit more objective, you can either use dynamometers themselves, where sometimes you can just flip one around and you do what is known as the push-off test, where you put it behind you and then you push off and it gives you a number. Or you can do a weight-bearing scale test, where you have literally a scale which you probably have at home, which costs nothing, where you can weigh yourself. You put it on the table, you put the hand onto the scale, and you put your body weight on it. And the nice thing, it can gives you the difference. So those two examples, for example, two tests straight away, can tell you how much load can someone put into that? So for me, if those two tests are really good, then you can interpret into that progression towards a sport or the activities that they can do. So, for example, if I've got a boxer, the ability to make a fist becomes really important, because then, if it's down by 50%, last thing I want them to do is to hit a bag. If when they squeeze, maybe there's only 10% difference, then their ability to hit a bag becomes better. If you've got a diver and they're struggling with their entry, and they do a squeeze, 100%, no issues, but then they go on the weight bearing scale test, which is a bit more loading, and it's down, then that obviously there's something to consider. And again, I've used those in a standing position, but we have to remember a diver actually is upside down with the hands there. So it could be that, you do them in a standing, and then you have to do them in a handstand position where you get them in a way that they can put their hand, one on the block, for example, and the other hand on the scale, and you see how much they're loading. So there are tools available, and I think, and don't get me wrong, we can start talking about range of motion and the way you can measure, but I've left that range of motion out mainly because I thought it's easier just to talk a little bit about loading and the ability of the hand and wrist to load. Same as you're doing with an ankle, is it? Can you do a knee to wall test? Can you do calf raises? Can you hop on the spot? Can you hop for distance? Can you hop for height? It's not much dissimilar on the hand. Obviously, you're not going to get them hopping on the hand unless, it's something that they have to do. But there are different ways of doing it, and there are different ways of measuring too, and getting numbers which can be used towards that prognosis, help with the diagnosis too. But also, as you are progressing, it's good to fall into something, because, 3 weeks down the line, 6 weeks down the line, are they getting better? Yes or no? Well, they might tell you, I don't feel I'm getting better. Or they might say, I feel I'm getting better. But then at least you've got something objective alongside, where maybe the symptoms have not got better, but the strength has got better, or their pain has decreased. So it's important to have something, in my opinion, objective to go together with the function as you are then increasing certain activities, be it athletic or non-athletic.
No, I love that, and I think your answer then was really helpful. It was nice to get some some tangible ideas of things that you do and ways that you do things, and I think for me those would be like the nuggets that I'll take home, from the content, in terms of like, these are the ideas that I just don't have in the forefront of my mind when I manage a patient in this anatomical region. And it's easy to have that library in other areas just by exposure and volume. So
and that's it. I mean, the other areas is a bit more exposure, and that's a good word that you've used there, because you talk about the ankles, you talk about knees, you talk about shoulders and backs. There's always more information coming out, but at least there's a bit of a template, and people sort of can fall back on those templates. And certain tests have been used forever, and maybe they've reinvented the wheel a little bit, or actually they've just rejiggled the old things in a classier format. But a lot of times you've got tools, is it? I mean, you think about the ankle, the knee to wall used to be using an inclinometer at first, and then they validated the knee to wall using a tape measure. So actually it's quicker and faster, but you can still use an inclinometer. Same with the hand and wrist. You can use inclinometers if you want to measure range of motion, and you can walk away from goniometer, same as we've done with the ankle, because loading an ankle is better than doing range of motion in a non-weighted bearing position, because the ankle is a weight bearing. So with the hand and wrist, you're not going to put them with the hand on the floor, but there are different ways of doing. One is the overpressure that you can create, and you can use inclinometers to measure. The other thing you can do is you can actually do something similar to a knee to wall, which is having the hand and loading it onto a table and then measuring that angle. So again, it's thinking about what are you trying to achieve in the context of their ability. If somebody tells you it's painful when I weight bear, and especially when I go down, you want to try and get that range in that position, not in a non-weight bearing position away from it, because you may find there's no difference, and it doesn't help you. So I think it's the knowing what tests are available, what tools are available, and then filtering that into the practice. And that's hopefully what we try and do with the diverse education we try and do around the hand and wrist, is get people a bit more aware of what things are available. A lot of things we have probably created because there wasn't, and we've done research also on certain things to help, in the vacancy of those things. But the main thing for me is trying to create that awareness, for people to sort of like really then make their own into their own practice.
I mean, I think you sharing things that experientially you've had to be creative and problem solve yourself is useful, because it's very easy via Instagram to go on and see a million and one different knee exercises or plyometric drills or agility movements. The list goes on. I might be looking in the wrong place, but I haven't seen many hand and wrist exercises being shared across Instagram. So I think even just it's just broadening that exercise library is useful, because it's so easy to consume ideas elsewhere. They're just put in front of you, and you probably know an exercise, prescribe an exercise that you've seen before, and you've got no idea where you saw it, because inadvertently you just consume this stuff online and on Instagram, etc., on a daily basis, probably. So I think that's really valuable.
Yeah, and I think it is interesting because obviously I think sometimes as therapists we over focus on the exercise rather than what the exercise is trying to achieve. And the problem
Mm,
with that is, you try and build 1,000 exercise library rather than, you know, what are you trying to achieve? Is it strength? Is it endurance? Is it this type of movement? And then it's good to have examples of. And I think what I try and do when I try and explain the hands and wrists is rather than go, well, here are 10 exercises that you could use at the hand and wrist, and then people get a bit lost. Or I'll give 1,000 exercises because you could do 1,000 exercises. It's like, well, these are the type of problems you could get, and this is what really the hand and wrist, what you need to think about. And you actually find that compared to other areas like the shoulder, for example, where there are probably a million exercises, and we know even from electromyographic studies that a lot of things don't do what we think they are, and it becomes the myth versus reality situation. I think with the hands and wrists, again, there's still a deficit around research. So, I'm trying not to shoot myself in the foot here. But the reality is that with a lot of conditions, um, you can do a couple of exercises that can actually cater for a lot of conditions, because what you're trying to create around the hand and wrist is there's elements of stability in certain areas, and then there's element of mobility. So it all depends, obviously, of your findings at the time. But definitely, there's a big thing about stability around the hand and wrist, because you think about the main injuries like TFCC, which is a stabilizing structure. You think about the scapholunate ligament, which is a stabilizing structure. The scaphoid gets fractured. The scaphoid is important in biomechanics, obviously, unless it's been treated non-surgically and it's gone nice and stiff and everything has got all stuck. Then maybe you think about mobility, but at least you've got full understanding that it is something that needs mobility. So it's having that element of, okay, I know what I'm looking at. I know what really I'm trying to achieve here, and then it's having a few ideas of these type of exercises. The nice thing with hands and wrist also, you can play with lots of little tools, and lots of colorful tools, but the bottom line is, it's not about just using a bit of putty and a bit of bands and fancy colored ones, which I do use myself, but actually using proper weights and
mm.
loading properly. And in the absence of finding a gym where they can do it, or them buying certain equipment, because that type of equipment, the lighter equipment, call it this way, is good for a period of time, but then you can't take them to the next level, especially if you have an athlete, not just an athlete. I mean, imagine certain, if you're a builder, if you're a roofer, if you're sort of somebody who's in a trade and they need that sort of that's proper strength, giving them a bit of banded exercises, even if they're hard bands, not to preclude bands completely, but you have to think about the resistance. So,
Mm.
I'm not trying to sort of discredit bands because bands are really good. What I'm saying here is you have to think about the level of resistance, and you have to think about how you're progressing that resistance. So you need the right equipment. And I know that because even when I have done courses over the years, um, you know, when I first used to go there, it just used to be a few bands there and a bit of putty, and they think, I can run a hand and wrist course just talking with that sort of equipment, which isn't the case. You need
Mm.
proper weights to actually get a proper shift around the hands and wrists.
No, good point. Obviously, the listeners and people that want to do this course can find it on informedperformance.com if they click through to the education page. For you personally, where's the best place for the listeners to follow you and track what you're up to?
Yeah, so like many, I'm on social media. So whether it is LinkedIn under my name, Ian Gatt, or you can find me on Instagram or on Twitter. So I tend to share upcoming courses so that people are aware of things that I'm doing. And obviously, because this is going to be pre-recorded, will be recorded. So hopefully people will join the live, but we'll keep on sharing this information so that people can access it at a later date if required. But yeah, follow us, and obviously you've got Informed Performance here, who will obviously be hosting these webinars, so they will be part of their social platform.
Cool. Good stuff. And mate, thank you very much for coming back on the show. And look forward to going live with you on the 26th of October.
Thank you.
Thanks, mate.